have known about, but welcome everyone to our October 12th edition of our West Region Learning Community for health departments and our amazing partners in the West. Today's topic kicks off our current quarterly pillar focus area of prevent. So welcome to prevent. And to kick that off, we'll have a presentation on some of the latest in the PrEP science. And we'll have a presentations later in the quarter on, Ty, remind me of the one that you all are leading.
Home testing.
Home testing, and then we'll have one in December on PrEP adherence. So welcome to, we closed out our diagnose pillar last quarter, and now onto our prevent pillar, and then more for you in our spring months. So thank you for joining, and some wonderful news you may all have or known or not known about, but our amazing Dr. Jess Bloom is expecting and had to jump to the hospital yesterday unexpectedly early. So we have Jonathan jumping in to substitute for her for the amazing slide deck and presentation that she pulled together today. So we'll send lots of virtual congratulations on the community's behalf to her, and look forward to her returning after her maternity leave. But just as an FYI, for any of you that are working with Jess or have been working with Jess, I know she's been reaching out to folks, but if there's anything you have pending with her that you need, you can please feel free to reach out to Jonathan or myself in the interim while she is away. And I believe she's scheduled at this point to be back at the beginning of 2022, I think around early to mid-January. So wonderful news there. For those of you that haven't already, please type your name and organization in the chat. And as we go through the presentation, there's going to be lots of information. So please feel free to type questions in the chat at any time. And we love those. And without further ado, I'm going to turn it over to the amazing Dr. Jonathan Fuchs to kick off for our presentation and then our interactive discussion for today.
Gary, thank you so much, and hello everyone. I've had a chance to meet many of you, but not all of you. So Gary, thanks for the introduction. Jonathan Fuchs, I'm with the Department of Public Health and also Professor of Medicine at UCSF, and excited to provide or to share some of these slides. Again, I cannot do justice to Dr. Jess Bloom, but I will do my best to share some of these key updates, and these are her slides. So I'm happy to take questions, but let's see. So as she did, and nor do I have any disclosures to share. The agenda for this brief discussion is first to describe the current FDA-approved PrEP medications. We'll talk a little bit about on-demand PrEP, or 211, as it's often known as, and then long-acting injectable PrEP, Cabotegravir. A few discussion questions to lead off here is first, how accessible is PrEP in your community? What's working well to increase PrEP access among priority populations, and what are some of the challenges? How accessible is on-demand PrEP in your jurisdiction? And then the third question is, anticipating injectable Cabotegravir approval, how is your jurisdiction preparing? What support might you need? So just keep these questions in mind, and I think, and I'm sure you'll have others, but we'll use these as kind of guiding questions for the discussion. So just to talk about PrEP effectiveness, as we all know, PrEP is highly effective, estimated to be at 99% effective in preventing sexual transmission of HIV, with data suggesting that taking PrEP, daily oral PrEP, at least 4 times per week can confer that level of effectiveness. Effectiveness is estimated to be between 74 and 84% for prevention of transmission from injection drug use. Because of the high, both the safety and efficacy and real-world effectiveness of PrEP, the U.S. Preventive Task Force have given PrEP a grade A assignment, which is extremely important in terms of approval for insurance companies for the reimbursement of for PrEP. And so that's a critical milestone to have reached this grade A classification. In terms of PrEP medications, there are two FDA-approved fixed-dose combinations. The first is tenofovir disoproxil in addition to FTC. Also, the generic is Truvada. This has been approved for persons weighing 35 kilograms or greater for any PrEP indication, including sexual transmission or injection drug use. In terms of adverse effects that have been identified, small changes in kidney function measurement or creatinine measurements, typically after discontinuation, improve, as well as there have been documented minor reductions in bone mineral density, but no increases in fracture risk. And so that's also important to emphasize. So that's for Truvada. The second agent, which is called Descovy, which is a combination of a modified tenofovir called tenofovir alafenamide, and that is in combination with FTC. This was studied in the Discover trial, and this is only approved for men who have sex with men and trans women weighing 35 kilograms or greater, but not for receptive vaginal sex. In terms of adverse effects that have been identified, small increases in LDL cholesterol, although in the clinical trials there have been no documented increase in cardiovascular risk. Also slight increases in body weight, that have been identified in the clinical trial. Another important note here is generic PrEP is here. Teva was the first company to have a generic form available broadly, and others are now offering generic Truvada, and others that are coming to the market. And studies have been done looking at the bioequivalence, for example, of Teva compared to Gilead's Truvada, and they are bioequivalent, and that's very important and important to share in terms of messaging with patients and clients who are interested in taking PrEP, that these generic forms are equally effective. Out-of-pocket costs are typically quite low, and so that's an important barrier that many people have identified. So now that generic is available, that is maybe an important way for people to find PrEP accessible. I did want to note, though, that in addition to, clearly we now have these very effective forms of PrEP, that in terms of PrEP awareness, their discussion with primary providers and actual use, when you stratify that by race and ethnicity, we do see significant differences. So for example, PrEP awareness overall is quite high among these different populations, particularly in MSM. But then when we start looking at PrEP discussion with healthcare providers, there's just a significant drop off. And then in addition, in terms of PrEP use. And if you look at PrEP coverage by race and ethnicity, this is from the AHEAD dashboard, which is a federal dashboard that's for the ending the HIV epidemic. There's a 2025 goal of 50% PrEP coverage, and for white men who have sex with men, that has already been achieved. However, as you can see in 2020 now, for both Hispanic or Latinx identified or Black African American identified, those numbers are substantially lower. So significant work that still needs to be done to ensure that PrEP is both is accessible for some of our focus populations to be able to address high rates of HIV infection. And in addition, in terms of not only looking at by race ethnicity, but also looking by age, again, young men who have sex with men also at particularly high risk for infection. Also, PrEP coverage is substantially lower in this group. So now I'll switch over to on-demand PrEP, or 211 as it's has been affectionately called. Dr. Molina published the critical study, the Ibergay study in 2015 in the New England Journal of Medicine. This is a sex-driven PrEP dosing regimen where 2 tablets are taken 2 to 24 hours before sex, 1 tablet 24 hours later, and then an additional tablet 48 hours after the first. Again, the Ibergay trial, this was a randomized controlled trial that looked at this event-driven PrEP versus placebo, and that was conducted from 2012 to 2014. Enrolled 400 men who had sex with men in France and in Montreal. There were 14 new infections in the control arm versus 2 infections in the treatment arm, with and that gives the 0.91 infections or incidence rate over 100 person years over a 9-month period. And the placebo arm was stopped early by the Data Safety and Monitoring Board in 2014. That gave an 86% relative risk reduction. And then afterwards, which was done for the IPREX trial, there was an open label extension study. And there they saw a 97% risk reduction. So in real world settings, when the efficacy was known of the regimen, the actual effectiveness of the regimen was actually quite high, 97%. In terms of on-demand, this was a very interesting abstract that was presented by Dr. Molina in Croy of this year, looking at demonstration studies in France, the Prevenir study, as well as the PrEP study, which showed comparable HIV incident rates in cohorts using both on-demand PrEP or daily PrEP. This was not a head-to-head comparison, but looking at these open label extension studies in these two settings, showing that both of these regimens are highly effective, and in this case, 361 HIV infections were averted. So again, an important key message to share with communities that both daily PrEP and on-demand PrEP are highly effective. However, on-demand PrEP in the United States, it's currently not FDA approved, but is approved for use in Europe, Australia, and Canada. In the US, clinicians can provide on off-label PrEP in an on-demand fashion. And in fact, the International Antiviral Society in the 2018 guidelines recommend on-demand PrEP as an alternative to daily PrEP for MSM who have infrequent sexual exposures. And we anticipate that the new CDC guidance, which we're hoping will be issued any day now, will be able to endorse on-demand PrEP as well. And as we know, programs around the United States are beginning to offer on-demand PrEP to expand options for patients and clients. And then finally, I'd like to just briefly talk about injectable PrEP. And this has been very exciting advance this year, long-acting injectable Cabotegravir produced by VIV. This has been recently demonstrated to be safe and effective in preventing sexual transmission for HIV. There have been I know this is a busy slide, but there have been two pivotal clinical trials conducted by the HIV Prevention Trials Network, one called HP10-083, which was conducted in multiple countries, primarily focused on cisgender men and transgender women who are having sex with men. And then the second, HP10-084, which primarily in cisgender women in a number of African countries. What's exciting here, and we'll send out these slides, of course, you'll have access to these. The key message that came out of HP10-083, this was a comparative study compared to daily oral Truvada, and showed non-inferiority of Cab-LA to tenofovir or Truvada. And in fact, they found that in this study that this was actually superior Cabotegravir compared to Truvada. There's a 66% reduction in HIV infections in study participants provided Cab compared to Truvada. In HP10-084, this was actually even more effective, and so that women in Cabotegravir had an 89% lower risk of HIV infection compared to the Truvada group. This is just a schematic showing the clinical trial design. In both groups, there was a pill group. There's group A, as you can see here, there's Cabotegravir, the active pill that was taken, and then moving into the injectable form that was taken every 2 months. So basically every 8 weeks an injection was given. And then follow-up there was daily oral Truvada that was given. This was compared, the injection compared to a placebo pill, tenofovir and FTC. Group B basically received a placebo for Cabotegravir and then received a placebo injection. However, they received active Truvada. And then again, with the everyday Truvada was not offered for that group again because they didn't receive the Cabotegravir. And so if you look at the study population specifically for HP10-083 in MSM and transgender women, you'll notice that about 12.5% of the population self-identified as transgender women who had sex with men. It was a racially and ethnically diverse cohort, and specifically in the US cohort strove to have 50% of the population self-identify as Black African American, and they met that target of about 50%. And then in terms of ethnicity, as you'll notice here, also a substantial proportion self-identified as Latinx. This is just a slide looking at the cumulative HIV incidence comparing HPTN 083 and 084, again, showing high levels of protection in both of these cohorts. So what's exciting is that Cabotegravir taken every 8 weeks has been shown to be superior to oral Truvada in preventing HIV infections in 2 large randomized controlled trials. There were some incidences of CAB failures, and so there's a number of studies that are currently underway to try to understand why that was a factor, whether issues around resistance to Cabotegravir in those cohorts. So more to come on that. It's not yet FDA approved, but has received breakthrough therapy designation by the FDA. And so we are hopeful that we may have approval in the coming months. I just wanted to make a note that if there are questions for clinicians in your jurisdictions around PrEP as well as PEP, there's the consultation line that's available. Again, this is free, the warm line. And so the number is here. Please feel free to take advantage or to promote this with groups that may be interested. And that's available from Monday through Friday, 9 to 8 Eastern time. And just to say a word about the pipeline for PrEP, there are many other agents that are actively being explored: implants, subcutaneous injectable medications, the vaginal ring, rectal gels and inserts and enemas, as well as other options for intramuscular injections and oral medication. So highly recommend you take a look at the AVAC website, which actively monitors progress in clinical trials for these different regimens. And I'll stop there and happy to take any questions.
So we do have one question, Jonathan, in the chat from Victor Ramirez in Washington. Is there any data of PrEP coverage by type of insurance? Excuse me, private versus Medicaid?
Was the question specifically in Washington State or nationally?
Just in general, yeah, nationally.
Yeah, it's a good question. I would have to take a look at the most recent. I haven't looked at the AIDSview website most recently, but that would be a good source of information. I will take a look at I will look into this. And if others have comments, if they know of other national data sources looking at uptake and variability by insurance status, would be great. Feel free to share. Thomas, do you have a question or a comment on that?
Hey, Jonathan. That was great, really helpful. What's the elevator spiel or the simple counseling message?
Around which part?
PrEP injectables.
They'll probably be FDA approved, probably if not by the end of the year, by early first quarter of next year. And really a lot of work now is thinking about how might we as providers support people for injectable PrEP that's taken every 8 weeks. So I think we have a lot to learn from the reproductive health world in terms of injectable contraceptives and what we can do to try to help people meet them where they are in terms of making that resource available to them.
Great. We have a question from Kirsten Sturba. Kirsten, it looked like you went off mute, but I don't hear you. Oh, now you're back on mute. Now you're off mute. Weird. There might be something with your mic. Feel free to type in the chat if you want to as well. And Preston shared the AVAC link with us as well. And Kirsten's going to type her question for us.
Oh, I was asking to get a copy. Can you copy and paste the link of the AVAC.org PDF chart that was featured?
Oh, in the slide deck?
Yes, please.
Oh, okay. Yeah, we'll share the slide deck right after the call today. Is that okay?
That's fine.
Okay.
And Ty, did you have a comment or question?
Yeah, I have a question. Thank you so much, Dr. Fuchs, for the PowerPoints and presentation. What could we do to increase PrEP uptake for women of color? It seems like that is a group that we're really struggling to reach.
Yeah, I think it's a great question. I think it's an open question for this entire group. I mean, I think in part, I think one of the I think critical work is the kind of the racial equity work that our health departments are actively engaged in, need to continue to support. I think what are we doing to try to address the implicit biases that in terms of our provider workforce, and are there ways, are we reaching and are we messaging PrEP in those in different contexts and where specifically cisgender women of color are accessing services. So I think those are some of, I think internally that work is really important. I think in thinking about how are we trying to meet the other services and other needs outside of PrEP, particularly for cisgender women of color, can we couple or think about how PrEP services can be more integrated into some of the other needs that are really more highly prioritized than PrEP. So I think those are some of the initial thoughts I have, but would love to hear from others who've really given a lot of thought to how they're trying to think about increasing access for cisgender women of color. Victor, did you have a comment on that?
Actually, I had another question. I think following up on Ty's question, it's about access to the population who do not access healthcare. I mean, and that's kind of where my question about Medicaid came from. I mean, that segment of the population who is not accessing health services. I mean, I could say maybe homeless populations. People who are suffering with mental health or substance use issues, or just in general, people who just haven't taken the time to either apply to Medicaid. Maybe they don't make enough money to be able to afford private insurance. Because I mean I think that's the population that we could get them just in general, just into the healthcare system, then we can start, be able to tackle that PrEP, the HIV prevention issue with them.
Victor, I so appreciate that comment. Thank you for that. And I think COVID has only exacerbated the, what the realities are in terms of access. And I'll say just from and one of the reasons I haven't been on several of these calls in the past, I'm activated for our public health department for our COVID response, and oversee our network of neighborhood vaccine sites that we've developed to offer COVID vaccines. One thing that has been really clear, early on in San Francisco, for example, there have been numbers that have suggested that upwards of 95% of the population are insured. That is clearly not the case. When we've offered done surveys of people who've accessed either testing or vaccines at some of our neighborhood sites, upwards of 40% of people who do not have a self-identified provider. So if that's the case, then there are communities that are not plugged into regular healthcare. So we need to be thinking about alternatives of where people want to receive care or other support services, or thinking about whether it's food support, linkage to behavioral health services, other places where people are accessing, they're not touching the healthcare system per se, but they are touching other places where services are offered. So how are we including the messages around sexual health services to be able to provide that? And in fact, one of our clinics in the mission has started offering HIV testing as part, in coupling that with COVID testing and vaccines. And so far, we've actually had great uptake. So I think thinking outside of the box about where people are accessing a wide range of services, and then trying to think about how we might integrate sexual health services and PrEP specifically might be one strategy. But and again, would love to hear others' thoughts.
Jonathan, Alicia Moorhead had a great comment in the chat. She was saying, yes, I've done some focus groups with Black women who mentioned the emphasis on reproductive health, sometimes over sexual health. And she would target PrEP training for OBGYNs who can teach patients about PrEP. It might also be, easier facilitation with the injectables as well there. And then Bev Wasserman had her hand up for a question. So Bev, I will turn it over to you.
Yeah, it was, thanks, Gary. It was just a comment kind of looping back on the discussion about insurance and women of color, engaging women of color. One of the things I know we've been thinking about, and we're planning a conference in December where we're focusing on sex positivity. You know, that's a real barrier, and it's a barrier in the provider, not so much our community, because we talk about sex and we're good with that and comfortable, but as we know, you know, as people are accessing primary care, that may not be the experience they're having. And again, it loops back with what Alicia said about really this training and engagement of providers that are outside of our primary workforce, because they are seeing patients, as we know, I think the majority of STIs, Jonathan, you probably know this better than I, are diagnosed in primary care settings or private clinics. It's not all happening in public health departments. So I just think if we can indoctrinate our fellow colleagues in healthcare with this idea of sex positivity and talking about sex and being okay talking about PrEP and PEP and not being afraid of that. So that's just what I've witnessed over my career, is this kind of fear around, for providers, around getting into discussions that they don't feel like they can handle.
Well said.
So Jonathan, I have a question for you and kind of the group. I know that we often talk about HIV transmission amongst racial groups, but have we ever tried targeting prevention methods to like sexual behavior? I know we talk about MSMs, but like, how do we target bottoms? How do we target tops or people that identify as verse, and make sure like maybe the messaging might connect more with them, and then that might bring them more into the clinics instead of targeting them as a racial or ethnic group?
Yeah, I think, I mean, early on, especially in the HIV epidemic, we, you know, as we learned more about risk factors for transmission, then I think I think there was a lot of more focused messaging on actual sexual behaviors, or as a way of thinking about both thinking about seropositioning and serosorting, your HIV status, and what type of position you took, you know, in sex. I think that now, I think as we're moving more towards kind of status neutral approaches, we're trying to destigmatize and not necessarily focus specifically on particular sexual behaviors, but trying to, and in fact, I think in terms of quote unquote, and then I don't like to use the word targeting or even focusing on populations, is really trying to think about this more broadly, rather than focusing on what are some of the population needs, what are the unmet needs, and how are we not meeting certain communities where we need to be. I think that maybe has been more of the shift in the conversation, as opposed to specific sexual behaviors per se. I think it is important to keep think about specific sexual behaviors in context, because as we know, for example, for certain agents, we know that they're not necessarily approved. For example, so for vaginal sex, receptive vaginal sex, Descovy is not an approved PrEP agent. So that's an important context. So to keep that in mind, but overall, and not necessarily targeting messaging around PrEP, specifically around behaviors, I think is kind of the current directions. And again, would love to other people's thoughts.
Yeah, Jonathan, I would agree with that. I do appreciate what you're saying, Jesus, with regards to just the term top and bottoming might communicate to the public or to consumers that there's an awareness there that such things exist, and a comfortability with regards to talking about sex. I do want to kind of add on to what Jonathan said about the UCSF efforts adding in HIV testing with COVID testing. They've also added on diabetes screening, and specifically among Latinos in the Mission District. And that is just an unmet need that's outside the box. It's not a communicable disease. Yet the disparity has been like, they did 100 tests and they found 9 folks that are either pre-diabetic or diabetic. So that disparity was just, and so it's kind of our foot in the door with an issue that is presenting within that particular community. And I feel like we can kind of ride that wave moving forward with drawing that correlation.
Great. We have a few comments in the chat. One from Ty about suggesting we focus on messaging for sexual networks, which definitely, SNS as a strategy, and really looking at how do you test or engage, with folks sequentially in a sexual network can be a very effective strategy. Frida also commented that there's a lot of stigma on PrEP use for women of color that is tied to stereotypes. And Alicia was saying, I think normalizing PrEP, like how condom use is generalized, may be helpful as well to decrease stigma. Jonathan, do we maybe want to share some of the guiding questions at this point? I'll give you a second to pull that up. Kristen has her question typed in now. Kirsten has a question about 211. So she says, I work with many individuals who are interested in on-demand dosing, and is it still recommended to discuss with a doctor to start this safely, for example, potential for flare for chronic Hep B, et cetera? Can you discuss basic talking points?
Yeah, it's a great question. So yes, I mean, I think, it is an individual discussion, I think, with the provider, what type of PrEP regimen is right for them. So I think, that then it's a discussion about planned versus unplanned sex, frequency of potentially having condomless sex. So I think all of those factors are really important, and that's an individual decision. But we've shown, and there are really good data now suggesting high levels of efficacy and also high level of safety. And that addresses the issue you talked about in terms of hepatitis B flare. So if someone had they already been tested, have they been vaccinated? And so that would be definitely a talking point. But overall, I think most of the concern or interest in is 211 right for me? It's based on some of the factors that I already talked about in terms of predictability of sex and frequency of condomless sex, and whether that, whether on demand versus daily PrEP might be right.
Great. And Jonathan, feel free, however you want to use the questions. And just to let you know, our folks are both chatty and familiar with the Socratic method of being called on, if you haven't heard from some of them or from some jurisdictions on the call. So please feel free to walk through these however you would like.
Sure, great. But before doing that, Patrick, I see your hand up. Did you want to make a comment?
In line with that Socratic method, right? Yeah, I was curious. I found Frida's comment really interesting, and I was wondering if she wouldn't mind expanding a little bit on access to PrEP with African-American women and stereotypes. So I'd like a little more information on what was meant by that, if you don't mind me putting you on the spot, Frida.
So most of the time that I have talked with some of my friends and wanting to know whether they use PrEP or they have ever heard about it, it's like the comment that comes after that, the word PrEP is like, so you already know that the society sees me as promiscuous, so why would I get on PrEP, and wouldn't that be reinforcing that stereotype? And so it feels very like when you talk with people, like women, especially of color, they just feel like it's another label you're handing on to them where they already have so many labels to deal with. And so I think that what I think is Alicia said, to maybe push the focus more on reproductive health more than or safety or health itself in general, rather than sexual health, would be a good shift, because it takes away the labeling or, oh, you're another PrEP user that's kind of is allowing yourself to like maybe have more multiple sexual partners and stuff like that.
Thank you. It reminds me, there's so many correlations between PrEP and birth control. And this reminds me kind of also of maybe the early days of birth control, that the women accessing birth control were those kind of women, So I'm hearing you say the same thing. Thanks for expanding on that.
Great. Thank you, Frida.
Dr. Fuchs, if you could speak up or move closer to your microphone.
Oh, sure. Sorry about that.
Hard a little to hear you.
Great.
Thank
Okay,
you.
good. Is that a little bit better, Ty?
Yes.
Perfect. Okay. So let's go into these discussion questions. So maybe we can just go around and talk a little bit about PrEP access, and specifically around increasing PrEP access among priority populations. What's working and what's still ongoing challenges. If folks want to reflect on that. So maybe we can go around to our jurisdictions on this call, and love to hear from you. Maybe we'll use Socratic method. I guess. How about Nevada? I'd love to hear, Lyle, if you're on the call, or if other colleagues from your team would like to share. Lyle, I think you're on mute. If you're.
What's the question again?
Sure. No, the question is just around PrEP access, particularly among priority populations. What efforts that the state has taken in working closely with local jurisdictions or with community-based organizations? What have you done to try to increase PrEP access, and what's working well, and what are still some ongoing challenges?
I think, of course, it's not bad. We have had a lot of people. In regards to Nevada, we've increased more PrEP access, like in our pharmacists being able to prescribe PrEP. That'll be starting effectively this month. So that's really awesome. Of course, in Northern Nevada, there's been challenges with getting more providers educated and getting more point that way. But I thought we've done a pretty good job.
Great. Yeah, I'm very interested. Will you be able to collect data, since with pharmacies potentially having increased PrEP availability through that mechanism? Will you be tracking PrEP prescribing and stratifying that by race, ethnicity, or by other, thinking about other priority populations by gender identity, to see if that is going to have an impact on uptake?
In regards to the data analysis for that, that's going to be a little bit more challenging, just because we'll have to rely on pharmacists. And there's unfortunately no ICD-10 codes that we perfectly isolate to identify PrEP clients, unless there is an ICD-10 code that I'm not aware of. That's an ongoing challenge to figure out the PrEP prescribing mechanism. But yeah.
Yeah, no, thanks for sharing that, because I think, and that is it is an important challenge to highlight, and it's important to try to address it and mitigate, because if we're trying new strategies and we're not collecting data on how effective they are specifically for our focus populations, then it's hard to do quality improvement around that, right? So I think we all are kind of enduring that. It's a challenge around data collection for, in multiple ways, that whether it's around testing or it's around thinking about PrEP uptake, but just as a kind of to underscore the importance of that, so we can see, are some of these new strategies that we're testing, are they actually getting to the populations that may need it most?
Of course. Is there, maybe this is a question posing to other jurisdictions, how are they isolating those variables? Just because, at least when we do our analytics pull down, we often find that it's harder to isolate individuals who are different, who are HIV positive, or individually are HIV negative.
Mm-hmm. Yeah. Others want to comment on that?
I can say I work for Ultimed, which is a FQHC in LA and Orange County, and we're still trying to build out our data collecting coding right now. I know that we're looking at certain ICD-10 codes Z20.6 is HIV exposure. It's commonly used by our providers for PrEP, but since it just says HIV exposure, it can also be used for PrEP. So then we have to put in the coding like, the PrEP medications, like for instance, Truvada was used, but not plus dolutegravir and raltegravir. So it does take a lot of trial and error and looking up and seeing like who gets pulled up when you put the coding this way versus another way. We first look at Z20.6, and then there's another common one that I'm trying to look up while I talk to you. High risk behavior, which is Z72.5. Those are like probably the most common ones that we notice providers using for the ICD-10 codes. So we're looking at that data, but you do have to go through and look at the patient charts and do chart review to make sure we're pulling up the right information.
I might have to rephrase my question. Maybe from a state perspective or a larger overall picture, because I'm like at FQHC, I feel like it's a lot more easier because you can look at those patient information directly right there in your own system, whereas at a state perspective, you have to look at like, hey, what's the overall bigger picture? We may not have the patient charts right there available to us. So, and even then, C20 or 69.2 and other those ICD-10 codes you mentioned, they can also be used for individuals who are HIV positive. So that's, yeah.
That's an excellent point, Preston. Thank you. Maybe we can focus a separate conversation during this around some of those data analysis challenges and how some folks are trying to overcome them. I think would be great. Several folks I know can help contribute to that discussion. How about, Colorado is well represented on this call in terms of that question about increasing access for priority populations. Anyone want to comment on some of the work that's happening there?
So I don't know if the health department is on. CDHPE, are you on today? I just see the Denver PTC staff. I can attempt to talk about what I understand that we are doing in our sexual health clinic, and I invite Bev or Azul or anyone else who knows to correct me if I'm wrong. So I offer this tentatively, Jonathan, afraid that I'm going to say something wrong here. What I understand our sexual health clinic to be doing to increase access, we are doing a series of targeted advertising to communities that are frequently not seen in large numbers in our clinic. So we're looking at the Latinx community, African-American community, and women with a series of targeted ads. We also we're going a long way to do teleprep so that to take away some of the stigma of coming in and asking, doing that. Bev or Azul, what else did I miss?
I think that's completely. I know they're working on a new campaign, targeted campaign with new marketing materials.
And Bev is putting up her hand. The one thing that I would say is that with anything that deals with sexual health and communities of color, there's already stigmatized that communities of color are one giant id. And we need to think about how we think about the marketing and encouraging people to be sex positive, because people talk about sex, but that discussion is not always sex positive. There's always an underlying undercurrent that some communities are oversexed, some communities aren't, some communities are asexual. So when talking about sex, we need to promote sex positivity. and think about the sexual networks that communities are participating in.
Great, thank you for that. Claire from Washington State, do you any comments here about some of the steps that the state has taken in working with partners with local jurisdictions or with CBOs around trying to expand PrEP access for priority populations?
Yeah, if Patrick Dinwiddie is on the call, I actually think I'd like to defer to him because this isn't my direct area, so I don't have a lot of knowledge. Patrick, are you on? And otherwise, I can look into this and kind of get back to the group in the online discussion board. But yeah, I don't have a ton of information about what's happening in our state right now.
Great, great. And
I mean, I
think
can.
was muted.
Oh.
This is Patrick. Can you hear me now?
yeah, we can hear you, Patrick. Thanks.
Okay, I was muted by the Zoom system as I called in, so I had to like *6 it.
Patrick, we were just asking.
Anyway, yeah,
about...
so I'm the.
Oh, no problem.
So I'm the testing coordinator in Washington State, but the partner I work with, Mike Barnes, he usually oversees these contracts that we have with CBOs around the state, some LHJs for PrEP services in terms of like PrEP navigation work, health benefits navigation work, and our target, or I shouldn't say target, our priority populations are well defined for our contractors to work with. And for the most part, I think they do work very well with meeting those objectives in terms of reaching priority populations. Most of those funded partners at this point are referring, doing active referrals for folks to get PrEP. However, we do have some of our funded agencies. I think there's maybe a couple of them. We have like 9 funded agencies we're working with. There's a couple of them, primarily in King County and Seattle, who are looking at developing PrEP clinics and have worked towards getting 340B access. So that looks like that's going to be coming online in the future, where they'll be able to actually prescribe there at the community test site at the CBO. So that's kind of where things are at a high level right now in Washington State.
Great. That's great. So trying to look at more lower the barrier by just having more places for access, and with trusted community partners being able to actually prescribe PrEP.
I think so. I mean, I think if you look at kind of the way it's worked or the continuum over time, first it was kind of, testing, and then it became testing and referral. Then it's kind of moved to active referral. Now we're trying to, and linkage, and now we're trying to move more towards, or at least some of our partners are trying to move more towards actually doing that in-house, along with an integrated testing approach, so that other services, preventive services, can be offered, and care linkages for different things can be offered as well. And then as far as data collection, and this is really not my area of expertise, but we are using Provide Enterprise, I think, to collect robust data on the clients that we're working with for these services, so that we have a better picture of what's happening in Washington State, who we're servicing, who we're reaching.
That's great. Thank you for that. Luis, I'd love to hear from you, if you don't mind, just in terms of the really important work that's happening in LA and how trying to increase access. Some thoughts?
Sure. I am kind of new in this position. It's been 3 months. I would actually, if you don't mind, talk about something else I've been experiencing, which is, so my staff, who is a client-facing positions, who are PrEP navigators or PrEP enrollment workers. And what I sense, and I've missed this in previous conversations, is their experience and the difficulties that they face. We're talking often of folks who are overworked, underpaid, and whose motivation to be in this job, especially here at the Los Angeles LGBT Center, since we are a very large queer community, which the workforce also kind of represents, it's also a safe haven for many folks to work. What I am dealing sometimes in terms of some challenges that I experience have to do with their motivation and with their engagement and their specific circumstances in sort of providing access to clients. And that's something that, I would like to know more about other people's experience with that, because implementing strategies and new initiatives always goes through them. They are the frontline workers. I'm slightly behind. Yeah, I've been really dealing with that.
Luis, thank you for bringing it up. It's such a critical part of the conversation, is focusing on our HIV prevention workforce, right? And so how the workforce is the critical pathway to the communities we're trying to reach, and how are we supporting or not supporting our primary, our frontline workers, I think is really a key point that you're getting at. So I think there have been conversations in this context, and there will be in the, months ahead. So let's keep that front, at the forefront.
Yeah, thank you.
Yeah, Luis, we'd love to follow up with you on some of that. We've been working with a number of CBOs in the LA region, and there are some similar things coming up amongst the CBOs down there, and especially as it's engaging priority populations, but also utilizing certain evidence-based strategies and things like that. So we'd love to chat with you more about that, one-on-one, offline.
Sure, I'm gonna post my email on the chat.
Oh, awesome, we'll follow up.
Maybe to shift gears a little bit to now 211 and on-demand PrEP. What are the kind of jurisdictions' experience has been around that? How's that working? In terms of clinics being able to provide it, client demand, any things that are working well, any challenges? Maybe going back to Nevada. Press, I don't know if you want to talk about, you or Lyle want to cover that.
While Preston is getting ready, I will say that here in Colorado at our sexual health clinic, our providers are prescribing 211 and they are finding it's going really well. I got an update on that today, so I am able to talk about that.
That's great. Good. Jesus, you had a comment on that, on 211?
Yeah, if you don't mind me sharing, a couple years ago when I was at a CBO, the leadership got the HIV team together and says, how do we increase access to the community we were serving? And that suggested 211. And the leadership wasn't too familiar with it. And then I explained, like, it wasn't FDA approved, but other countries have approved it. There's some science behind it. And the medical director said, I'm not doing that because I don't want the liability on the organization and things like that. So I'm wondering if other jurisdictions have had those experiences and how you would coach them to kind of think about, reconsider having 211 as part of the services that they would offer.
It's a concern that I've heard expressed out as well. I think for clinical providers, they're aware that they are allowed to prescribe the medication, quote unquote, off label, if not on a daily indication, in the 211 fashion. So just to kind of reassure folks that they're the organization is not liable in any way. Individual providers are responsible for prescribing PrEP, and so and it can be done in that fashion. But just want to just make sure that that's really clear for our group here. But that would be a key talking point that we'd want to be able to emphasize. And the data are, as I shared here, and happy to kind of review that at any point if folks have additional questions about it outside of this call, but it's pretty compelling. 211 can be highly effective and safe for the population. And there are a lot of other positives. For people where sex is more predictable, again, it's fewer pills, less burden, might be easier, and then in terms of cost, again, a lot of important considerations. So if it's the right context and within a conversation with provider, it could be a really great option for people. Carolyn, did you have a comment on that?
Yeah. Oh, I just first wanted to introduce myself to everyone. Hi, I'm Carolyn. I'm actually with the Santa Clara County STD HIV prevention program. It's actually my second week into the job, and so I just
Yay,
welcome.
It's
my first meeting here too, so I wanted to thank everyone. It's so great to hear from all of you and getting to meet all of you. But I think as far as 211, so I'm actually still doing a lot of research in this new position regarding the programs that we already have, and it seems like we have a pretty great initiative already continuing. It's the Getting to Zero program. But as far as 211 and some of the challenges that I'm kind of learning as I'm getting more acclimated to this role is definitely academic detailing. So once I kind of learn more about whether we have the 211 kind of program going on, I'll definitely take a look at if we can include that in academic detailing. But what I'm seeing so far in our program is that we kind of have some challenges with, speaking to providers and kind of building not a better rapport, but I think just being able to provide them with the support that they need. And so I think that's kind of where I'm kind of learning how I can help them better. But just wanted to say hi to everyone and thank you, and to share with you a little bit about what kind of I've seen in our program and some of the challenges that we have.
Great, thank you for that. Anyone else want to add?
So far for Nevada, we're not doing 211 quite yet. However, on our nhbnevada.org website, we do have a provider directory list where we encapsulate a bunch of providers statewide with their addresses, phone numbers, and then ways to get in contact with that medical provider.
Great.
Great. Oh, and I was just going to say, Carolyn, I put some info in the chat. Please reach out to me around academic detailing. We have a learning community for that as well that meets on the third Thursday of every month, and just happy to loop you into everything there, and others who are interested in doing detailing for providers around this topic.
Great. I'm gonna have to jump off the call in just a few minutes, and I just wanted to maybe ask a little bit about Cabotegravir. And this will not be the only time we're talking about this, because again, as soon as FDA approval happens, there's gonna be a lot of conversations about rollout. But just any initial impressions that folks have, or what you're thinking about, or as part of your community advisory boards or discussions about what will this be like to roll out injectable PrEP?
And as you're thinking about that, our call is still going to 12:15. Jonathan's just going to hand off to me when he needs to leave. The dynamic conflict of COVID and regular work going on at the same time. So we'll continue to carry on the conversation. But yes,
thank you.
Thoughts on Cabotegravir implementation? Is anyone preparing for this at all, or thinking about it? Or is anyone like, oh my gosh, could you help me prepare for this? Patrick's saying at the CBO level, I think about who would provide the injection and what kind of credentialing they would need under Washington administrative rules. So yes, a different world given that it's an injection rather than just the tablets.
I mean, I was going to say, if it's a medical provider who's there, like the ones who want to provide PrEP now at some of our agencies, that won't be an issue. But when we start getting into the realm of regular staff doing this work, like doing phlebotomy work, we have rules for that and credentialing and things like that. So it's just something interesting to think about. So I don't think we're there yet in terms of, how this is going to work. But this conversation has caused me to think about those things, that particular issue.
Great. Nevada, Southern Nevada Health District's talking about that they're educating clients about it. Alicia's talking about, wondering just about insurance coverage and payment, and, what, if any, different steps or system there will be for that. Jesus brings up an important point in the chat as a PrEP user, really having that conversation of, do I really need to switch? If the daily pill isn't a big deal for me and I'm, adherent and all of that. So, and Kirsten was talking about wanting definitely some help and some TA around preparing for injectables. Thomas is talking about it's going to be a hard sell. The tablets are easier to sell to people. Thomas, do you want to say a little bit more about that? Jump on audio. What about it do you think is more the hard sell?
Just people in general seem to think that injecting something into their bodies is not a great thing to do. They're just injections in general. They're like, no, I don't want an injection.
Right.
Look at the coronavirus and the vaccines. People don't want the injection for whatever reason.
Yeah, good point. With hesitancy around a current injectable that is already going on out there. Patrick was saying reminds him of COVID. Yeah. What about some of our more Jonathan, I know you have to jump off soon. What about some of our more of our rural or frontier states? Andrew, what's happening for you and Wyoming folks? What's happening for you? Let's maybe go with Andrew first.
Well, this discussion of injectables is interesting because obviously the injectable ART for people with HIV came out, it's basically a year ahead of PrEP, and it's a hard sell too. And it's very complex. So I think for most people, when there is injectable PrEP, I would talk to the ADAP folks and figure out how they figured it out, because there's crazy stuff like it's not billed as a pharmaceutical under some insurance plans. It's billed as a medical visit, part of a visit. So that makes it more tangential to a traditional ADAP, but we're allowed to pay for it with ADAP. HRSA gave us permission. So what will that do for everyone depending on the income from pharmacy for PrEP? That's going to be a really interesting question. And, the once monthly has not been that popular because that's a lot of visits, even more so in rural frontier areas where transportation's an issue. With if PrEP's going to start at every other month, that's a huge difference. And I know they're looking at all of them for every 3 months. For people who don't want to see a provider as often or can't or have transportation, that and reimbursement are going to be really interesting issues to face. But ADAP at least is a little bit ahead, although ADAPs are struggling with injectable Cabotegravir. It's ridiculously complicated. The pharma is not being helpful, even though you think they'd be pushing it out. So let's see what happens. Just because it's released doesn't mean it's accessible. How slow was PrEP uptake in the early Truvada days? And it wasn't just because we weren't pushing it.
Excellent points, and referencing back to lessons learned early, with the PrEP strategy overall. Javier, you have your hand up. Please jump in.
Hello, everybody. I'm Javier Salcedo at Oregon Health Authority, and around Cabotegravir, I'm actually, I'm trying to look at the benefits and seeing, I see it's a hard sell. I know that, kind of infrastructure and things haven't been made in order to to really see us play out. But let's also look at the benefits. Look at like being maybe at syringe access programs if your state has them available to us. I also think that it'd be great with trans populations. I was previously managing a trans health clinic at an FQHC, and hearing preliminary things about that and knowing that a lot of folks that are transitioning are utilizing injections already, so they're very used to it. They're coming into the office sometimes on a more regular basis, or those that don't inject themselves. We always had a phlebotomist on board helping with injections and having a provider there. So I do think that there are populations that might might have adherence issues or not be better candidates for this. So I think we also have to look at that side of things and not just try to look at folks that are regularly taking the pill. Just gives us another opportunity to really diversify how we go about the rollout of PrEP, and really seeing this as a new opportunity for us to sell it to another community that might have not ever seen it as a viable option for them.
That is such a great point that, just because there's a new tool in the biomedical prevention toolbox, doesn't mean we have to go full tilt with it and, be pressing it for everyone. That, and I think this is, the more effective work with our priority populations anyways. We need to think carefully about who will most benefit and where it's best accessed and who's really primed to be able to deliver it or be more accepting of it. So those are phenomenal points, Javier. Thank you so much for sharing that. Others, are our Wyoming partners still on the call? No. Others, anyone else thinking about this?
There seems to be a lot of discussion in the chat though, Gary.
Yes, so let me grab a few of those. Thank you. So folks were saying, Okay, so Preston had a great question about, does the pharmacy board cover the PrEP injectable, or is it outside of scope? And Jonathan was responding that to be determined in terms of coverage on that, waiting the FDA approval before that can happen. Cheryl was talking about some folks in Southern Nevada Health District being really excited and interested. And again, there's nothing wrong with process of attraction. We don't have to push things out for folks, but just talking about that something is available and talking about what it means, can be engaging enough for some folks to, bring them in who are more ready or more at that stage. Luis was saying, we have challenges obtaining adherence metrics for PrEP, which is such valuable data to measure the success of certain initiatives. Injectable PrEP would be a game changer in that context, right? Because since they have to come in for the injectable, a lot easier to have for your record that this is actually happening and going on. So great point around that. Jesus was saying that Javier was just reminding him of some trans clients he had when he was a navigator at an FQHC. They were also sex workers and had really, had unstable situations. They traveled a lot for work and shelter. It was difficult to maintain a routine of daily pills. I think they could have benefited a lot from an HIV prevention injectable. Great point, Jesus. And I think of even medical services provided at homeless encampments and, of other folks who are saying just IDUs in general, so I think, there are some ways for us to think about this with some key populations. Cheryl was talking about going back to the discussion about family planning and PrEP. Depo and PrEP might be an interesting approach for certain populations, especially our family planning folks. And I think someone was talking about that earlier too, that maybe reaching out to the OBs and getting our PrEP uptake among women, on a better upward trajectory could be really helpful with the injectable. So great comments all. It's about 12:08, so we're going to just begin our wrapping up, but feel free if you have any last minute comments. Jesus will share the evaluation link in the chat. As always, it's critical that you fill out the evaluation, and we encourage everyone to do that since we all participated in the call. Please make sure to click on that and open a new window now before we end the call. The link will not be available to you after we end the call. So please just take a moment to open that up. And you can even start filling it out. As always, our evaluation is very brief. Next, we're looking at really starting to look at some of the broader impact of the learning community and where we might be going. You may or may not be familiar with, now is the time of year where the CBAs write their work plans for the next CBA grant year, which runs April 1, 2022 to March 30, 2023. So together, our three projects, are thinking about the proactive work that the directly funded health departments have in what's called your jurisdictional CBA plan. We're looking at some of the ongoing work that we have with the non-directly funded health departments. There's a new CBO grant and CDC is doing an assessment there. We are looking forward to the results of that, but have gotten some early feedback from CBOs on some priority topic areas. So we encourage you to keep telling us about priority focus things that you want to focus on for moving forward, even for this year. But we want to do a little survey. It might be tacked on to the the brief session survey for next time, but we're still talking about it and developing it. We'll give you a heads up and let you know when it will be. But just wanted to give you an early heads up that we want to be asking some questions about the potential impacts of doing this type of learning community work. We promise to keep it as short as possible. But right now we're still reviewing that and developing it and sharing it among CBA partners. So that's just a heads up for what's coming. Our second, our academic detailing, our public health detailing call next Thursday, same time as this, 11 to 12:15. We will be continuing to focus on identifying providers for detailing, and then we'll have some exciting topics announced next week for November and December. Again, our topic for this call in November will be home testing, led by the fabulous folks at the Denver Prevention Training Center and Mr. Ty Edward Few and his team. And the call for December, we're focusing on PrEP adherence. We hope to have our PrEP adherence guide for those who are on the front lines ready and cleared by CDC to launch for that call or shortly after. So some great things coming up over the next few months to get us into 2022. We also have our PrEP financing webinar that's currently in clearance that we will be doing. Once we get clearance, we'll set a date. So that'll be sometime between now and the end of this year as part of our prevent pillar focus for this quarter. Just wanted to open up Ty and see if there's anything coming up with the Denver PTC CBA that you wanted to mention at all, or folks from CAPTC. Any webinars, tools, anything coming up?
No webinars coming up, but we are still working on our toolkit, the early initiation of ART toolkit that will be ready in February.
Great.
2022.
And anyone from CAPTC? Any key products or webinars you might have coming up? It's okay if you don't. Sorry to put everyone on the spot. While you're thinking, we redid our rapid detailing aid. If anyone's interested in getting copies of that, it's on our website. And we're working right now on a pharmacy detailing aid that's going to be, I think, really good for PrEP. So look forward to some of those tools coming as well. As always, thank you everyone for an amazing, amazing call. Thank you for your robust participation. We will save the chat and capture things in notes. And as always, two things will happen following our monthly call. One, we will gather evaluation results, the notes, and the recording from the call and post that in the blog section of GroupSite. So gowest.groupsite.com. If you're not a member, please go there and request to be a member, gowest.groupsite.com. And secondly, we will put the guiding questions in a chat and continue to talk about these issues in the learning community. So a way to just continue as you think of more questions or you do more things around this topic, we will kick off a discussion thread in the group site as well. And Jesus, thanks so much for putting that link. So definitely everyone click on the SurveyMonkey before you leave. And if you're not a member of the group site, click on that group site link and request to be a member before you leave. Jesus has got it down to like 1 hour or less approvals on that. So please feel free. And thank you all for an amazingly successful call today. Have a good rest of your week. Bye, everyone.
Thank you.